in pathology. Today we are having a slide seminar and the topic is liquid-based cervical cytology, a case-based approach. Chairing today's session is Dr. Charanjeet Ahluwalia. She's a professor and consultant in charge in histopathology and cytology unit from Safdarjung Hospital, New Delhi. The faculty for today's session are Dr. Jennifer, professor from the Department of Pathology from CMC Vellore, and Dr. Hemant, the assistant professor at CMC Vellore. We have students from across the country. I request the students to introduce themselves to the audience. Dr. Ayushi.
Good evening, respected sir and ma'am. I'm Dr. Ayushi Chak from SGPGI Lucknow, JR2.
Dr. Sweetie.
Good evening, everyone. So please, how MCH now?
Dr. Rajiv.
Good evening, everyone. Myself, Dr. Rajiv Vijay Kumar, PG first year at Albuquerque Mother Medical College, Supreme.
Dr. Shelly.
Good evening, everyone. I'm Dr. Shelly Verma, PG second year, GMC Bhopal.
Dr. Sajjana.
Good evening, everyone. I'm Dr. Sajjana, GR2 from Dharan, Nepal, BPKHS.
Dr. Asif.
Good evening, ma'am and sir. Myself, Dr. Saif Ali Nakwa, second year resident from Grand Government Medical College, Mumbai.
Dr. Akansha.
Good evening, everyone. I am Dr. Akansha, GR2 from SRMS Science, Delhi.
Dr. Vinod.
Good evening, everyone. Myself, Dr. Vinod Kumar, PG first year, GMC Datia.
Pratik.
Good evening, everyone. I'm Dr. Pratik Minch, JR second year from AIIMS Bhopal.
The plan for today's session, these students will be interacting with Dr. Jennifer and Dr. Hemant, and we as the moderators will be taking up the questions which is coming up from the chat box, if any, to the speakers for their clarification. Myself, I'm Dr. Ramaswamy, and along with me is Dr. Mohini. We are the moderators for today's session. The webinar hosts are Dr. Anita Borges and Professor Sumit Gujral. These are a couple of instructions for all the participants. And one main instruction is please do not send requests for annotation, as this will disrupt the flow for the teachers. A couple of disclaimers. Before we proceed into the session, a quick reminder that we have two upcoming talks. One is a slide seminar on a laboratory approach to leukemia as a case-based approach by Dr. P.G. Subramaniam. That's coming on 12 September. Another one, we are having a cervical biopsy interpretation, again a case-based approach by Dr. Fabiola Medeiros from the United States. And now I hand it over to the speakers.
Can I share my screen, sir?
Yes, sir, please.
Is my screen visible?
Yes, can you make it full screen, please?
Yes.
Yes, thank you.
Okay. So good evening, students. We'll be going through like this. Initially, we'll start with a little history of cervical cytology, and then we'll go and discuss the adequacy criteria, what are the techniques we use, the difference between conventional and liquid-based cytology. Then we'll be seeing some pre-test images, which you can just quickly note down the answers to yourself. And after that, we'll go into the cases. Some of the pre-test questions will be discussed as part of the case study, and whatever is not been discussed will be discussed at the end of the session. So let's start with the history of cervical cytology. I think we have 3 students who are discussing the normal cytology. So normal overall attending?
Yes, sir.
Yes, sir.
Okay, so what do you mean by cervical cytology? What do we actually see? What part of the body do we examine? The uterine cervix, right? So, but when the cervical cytology was initially developed or was in the stages of development by George Papanicolaou, it was based on the vaginal smears. He used a pipette to collect samples from the vagina, and he created smears with it, and he examined them and compared it with the biopsies, and he developed the vaginal cytology. But what we now see is from the uterine cervix. So in 1943, Papanicolaou and Trott is a gynecologist. They together published Cancer of the Uterus, the Vaginal Smear Units Diagnosed. This was the first paper describing the utility of vaginal smears in gynecological cancers. So any idea who this lady is? Sweetie? Okay, so she is Mary Papanicolaou, George Papanicolaou's wife. So what is her contribution to this? So he was born in Greece, and he then moved to Germany for army training. Then he came back to Greece, served in the army. Then after that, he left and joined and reached the United States, where he joined a small lab and started researching. And he had an interest in, he wanted to examine the cytological aspects of gynecological cancer, but the initial samples or the comparative samples where he examined the normal cells from the vaginal canal came from his wife. For almost 20 years, she helped him collect samples from herself and contributed so much to development of the cervical or the pap smear, which we actually call. Any idea who this person is? Sajana? Rajiv? What is this stick-like thing?
Spatula.
Spatula.
So what is it called?
Cervical spatula.
Ayers apula.
Yeah.
Ayers spatula.
Right. So this is Dr. James Ernst Ayer. He is a gynecologist and a cytopathologist. He said, instead of sampling the vaginal canal, we can as well directly sample the uterine cervix. And he developed this wooden stick, which is now used. Now we prefer to use plastic spatulas. So after this uterine cytology was developed, there was a paper published in 1954, and they said present evidence suggests that cervical cancer, when present, has already been there for several months, and therefore a female population always contains many individuals with cervical cancer in various stages of development. If carcinoma in situ of cervix is the usual precursor of invasive carcinoma, then this will be the new stage of recognition of the disease in the population which is being screened, which means this cytological screening program was implemented. The diagnosis of carcinoma cervix was at the stage of carcinoma in situ or the pre-invasive stage, wherein you can prevent an invasive disease in the future. So based on this, Dr. Harald Hausen, he identified the human papilloma virus. So what is the role of human papilloma virus in cervical cancer? Dr. Sweetie? Sajana?
E6 and E7.
That is a pathogenesis. So almost all of cervical cancers are due to human papilloma virus, right? So Dr. Hausen, he received the Nobel Prize for it in 2008. And this was the first image of human papilloma virus which he published. Right, so when coming to human papilloma virus, we use these terms, low risk HPV and high risk HPV, based on how much it is associated with development of cervical carcinoma. So all squamous lesions which are non-cancerous, or the low-grade lesions or the low-grade squamous lesions, they are associated with low-risk HPV like 6, 11, 16 and so on. Whereas those human papilloma viruses associated with cancer, the 16 and 18, yes? Okay, so these high-risk HPVs are associated with a high risk of development of cervical carcinomas. So the interpretation of cervical cytology is based on the Bethesda system of reporting and it has certain categories under it. So first, what we evaluate is the specimen adequacy. Then there are certain diagnostic categories like negative for intraepithelial lesion or malignancy or no abnormality detected. Then interpretations like non-neoplastic findings, which includes a list of things, organisms, epithelial cell abnormalities, which can be squamous or glandular, and several other malignant neoplasms. So before that, Dr. Sweetie, what type of preparation have you seen before, conventional or LBC? Dr. Sajana?
So conventional one only.
Okay. So Dr. Rajiv? Okay. So the conventional smear is usually prepared when the sample is collected using an IS spatula and it is spread manually along a glass line, fixed in situ and sent for staining. So this is how a conventional smear looks with, this is a stained smear, we are just looking it from above. So the streaks represent the cells which are being spread across the slide. Whereas a liquid-based cytology, which was introduced in 1996, was initially by this company, the ThinPrep, and it was followed by the other company, SurePath. We'll see the differences later. So this is how a liquid-based cytology slide looks. You have a circle of cells which are deposited onto a glass line. Okay. So between these two techniques, the ThinPrep is based on suction. So what happens? The sample, after it is collected using a broom or a spatula, is mixed with this fluid, which is a methanol based preservative, where the cells are put into suspension, and this sample is sent to the lab where it is loaded into the ThinPrep machine, where the cells are mixed thoroughly. And what this methanol does is it lyses the RBCs and the mucus. So when we so Dr. Sajana, you would have seen a conventional smear, no? So what do you think obstructs your view of cells in that?
It's the background back debris and other
right. So you get those inflammatory cells, blood, mucus, all those obscuring the cells, right? So those things will be lysed in the preservative itself, so that the cells are better visualized. And after it is mixed thoroughly, a suction is applied through the stem, and all the cells go and stick to the bottom of this cylinder. So then this cylinder flips 180 degree, and the slides are deposited, and the cells are deposited onto a slide, which is then stained. And ThinPrep has a diameter of 20 millimeter. Whereas in SurePath, the broom which is used to collect the sample is detached from the stick, and it is centrifuged, and it is transferred into a sedimentation tube. It is based on density separation. So all the mucus and everything stays on above, whereas the denser cells settle to the bottom. So this cylinder is then placed on a slide, and the cells are collected onto the slide. SurePath has a diameter of 13 millimeters. So what is the advantage between this? We have already discussed, but is there any clinical significance between conventional and liquid based? So studies have shown that there is no difference in detection of squamous lesions between a conventional smear and a liquid based cytology, but it makes examination more convenient because of lack of inflammation or any obscuring elements in the smears. So as we already discussed, this is how a conventional smear looks. You can see cells layered on top of each other in clumps, and sometimes the inflammation can be severe so as to obscure the visibility of the squamous cells. So that is one issue we face with conventional smears, and we are forced to look at areas which are more well spread and well visible. So coming to adequacy of the smears, smears can be classified as satisfactory or unsatisfactory. It is called unsatisfactory when more than 75% of the squamous cells are obscured by any reason, any drying, hemorrhage, or inflammation. Anything other than that, it is satisfactory. Now, in examination of the satisfactory specimens, we should inform in the report about the presence of transformation zone. Why is that important, Dr. Rajiv?
HPV shows epitheliotropism towards the transformation zone.
Okay, so what is the transformation zone?
Sir, it is the zone where the squamous epithelium is converting into the columnar epithelium from ectocervix to endocervix.
Okay, so why is it so vulnerable to HPV?
Sir, because sir, it can easily enter those cells, the HPV virus. It
So
enters.
the transformation zone is where the epithelium is the thinnest. And the HPV can easily reach through micro wounds in the epithelium. Which part of the epithelium? The basal cells, right? So that is why when we say that the transformation zone has been sampled, it serves as a quality indicator that there is a good chance of detecting squamous or glandular lesions from that site. Okay, and any specimen which has any abnormal cells, squamous, glandular, whatever it is satisfactory, and we do not call them unsatisfactory just for lack of adequate cellularity. So next comes to the topic of adequate cellularity. So in conventional smears, the adequacy criteria is 8,000 to 12,000 well preserved, well visualized squamous cells. So this is very important. Even if you have millions of cells, if they are covered completely by inflammation of blood, then it would not be an adequate smear. For an liquid-based preparation, it is 5,000 squamous cells. And in patients who have received radiation, chemotherapy, hysterectomy, in those conditions, a cutoff of 2,000 squamous cells is recommended in both conventional and liquid-based cytology. So any doubts so far? Sajana, Rajiv, Sweetie, or any other students? So again, if you detect any abnormality, irrespective of the cellularity, it is adequate. So if you find some abnormality, do not call that smear as inadequate just because enough squamous cells are not there, right? So now we'll be going to see some pre-test spotter images. We'll give around 10 seconds per slide. You can just note your findings. And they'll be discussed as part of the slide session itself. So the first question is this. The next one. We'll go to the second spotter. Next one. Next one. Please don't share the answers on the screen. You can evaluate yourself when we discuss the answers. So this is the cluster you need to look in this spotter. So next one. Go to the next spotter. Next one. So you mark the cells which you need to concentrate. The last one. So
I think Dr. Hemant, before you can start the case, a quick clarification from the audience. How do we need to really count the cells for adequacy? It's a
yeah,
question.
so Bethesda does not recommend counting the cells, but they have given certain formulas and reference images. For conventional smears, we have reference images in the Bethesda Atlas, and it gives an indication of if the cellularity looks like this will be the approximate cellularity. So when you are examining a conventional smear, you can use the Bethesda Atlas to compare it. For an LPP, they have given certain formulas to calculate. So you can take any random field in the random representative field in the LBC smear and you can calculate it. You need not count the individual cells.
Thank you.
Yes. Are there any other questions, sir?
One more is there any really an advantage between sure path and thin prep? Or it's versus both of them?
No, sir, there's not much advantage in between sure path and thin prep in detecting squamous or glandular lesions.
So the only thing is, I would, just one addition. What the studies say that in thin prep, probably this yield of cells, squamous cells, may be a little less because there's a filtration membrane, and if there is a lot of mucus in the slides, then the filtration membrane may be obstructed, and the yield of squamous cells may be lower. Otherwise, there is, as Dr. Hemant said, there is not much difference between the two.
Yes.
Thank you, ma'am.
And one more important thing you need to know is between a conventional and a liquid-based preparation, cells are little smaller in liquid-based cytology. So the cells will look a little smaller, and you need to set your criteria based on the preparation in which you are examining. Also, the glandular clusters tend to be more compact in a LBP when compared to a conventional smear. So now I think we can get into the cases. First case, Dr. Sweetie is there?
Dr. Sweetie, are you there?
I think we lost her. Anyway, we can go to the second.
Dr. Sajana, can you please read the history?
Case 1, 30 years old female, routine screening, thin prep.
So most of the cases you will be seeing will be part of routine screening only, with very few patients coming for any specific symptoms. So what do you see here? Do you want to describe this? Just say, what do you think you see? What are these?
These max.
What are these?
These are superficial squamous cell.
So they are basically squamous cells which we are seeing in this field, right? So these squamous cells are, you can see here, they have angulated margins, abundant cytoplasm and small nuclei, right? So what we see here are the superficial cells. They are derived from the outermost layer of the cervical epithelium, and they are seen in the proliferative phase of the cycle. The nucleus is highly condensed, so you can see very dot-like nuclei, right? Hardly see any chromatin characteristic in this. They are very tiny and condensed nuclei, which is 10 to 15 micrometer square in cross-sectional area, and the cytoplasm usually is orangefilm. So now this one, what do you think these cells are?
These are intermediate cells.
Why do you think they're intermediate cells?
Folding of the cytoplasmic membrane and along with the size of the nucleus,
Yes.
a bit larger, and granular as well.
Right. So when compared to the superficial cell, which had a very pycnotic nucleus, like this cell. So like this cell, which has a very pycnotic nucleus, this cell has a bigger looking nucleus and which has more cross-sectional area of around 35 micrometer square, like these cells, these nuclei, this nuclei, and some of them may even show grooving like this one or like this one. Can you see the groove? So why is the this information required, the area of the intermediate cell?
It is
Yes. So that's the reference size for
other cells in this cervical cytology.
Yes. So when you are examining a smear, your first step would be to find a normal intermediate cell in the smear, which you will use as a baseline for comparing any other abnormalities. Right? Okay. So what are these? You see a lot of bacteria in the background, which are the lactobacilli. So what cell is this one? It's more likely to be a superficial cell.
Superficial cell.
Yeah. So next case is Rajiv there.
Yes, sir.
Yeah. So can you
50-year-old female, post-menopausal bleeding.
Yeah.
Pathology.
So okay. So what do you see in this one?
So these are like atrophic squamous cells. Very.
So why are you calling them atrophic squamous cells?
So there is small cytology.
Okay,
the size
so
of the cells is very less, and the crowding is more.
Okay.
Some superficial squamous cells are seen, and very few. So the image is not too much enlarged that.
Yeah. So, in this image, what you can make out is the cells are more clustered or forming sheets.
Yes, sir.
Yeah, rather than single cells, which we saw in the previous image, right? So that much we can make out in this image, and a lot of inflammation in the background. And the cells are much smaller than the previous images. So these are primarily the parabasal cells, which we see here. So these ones, this one. So they are more rounded, smaller than the superficial or intermediate cells, and they have a larger nucleus. And the cytoplasm is dense when compared to the intermediate cell. So how do we describe the cytoplasm of an intermediate cell? It's almost translucent, the superficial and intermediate cells. You can see light nicely passing through the cytoplasm. Whereas in a parabasal cell, the cytoplasm is dense. So the light doesn't easily pass through. That is why when these parabasal cells come in sheets like this, the light cannot easily pass through. That is why you have difficulty in interpreting these clusters. Okay. Yes. So you see these clusters. When do you see these clusters? Why do you see it in a postmenopausal female?
Sir, the hormonal, because estrogen is prevent to superficial intermediate cells, and after postmenopausal patients or
yes. So any low estrogenic states like perimenopausal, postmenopausal state, pregnancy, or post ovarectomy. So whenever the estrogen levels are low, you start seeing more of parabasal cells because the normal squamous maturation is dependent upon estrogen, right?
estrogen.
So in any situation where the estrogen level is low, you start seeing more of these parabasal cells, and atrophy is a pattern of this one of interpretation. And one more type of squamous cells which we need to see are the metaplastic squamous cells, and you can differentiate them from parabasal cells in that they are more angulated. Can you see the cells? The previous parabasal
spider cytoplasm cells, spider cytoplasm cells.
Yeah, so they have, can you please repeat?
I think some of the audience can't see the pointers, Dr. Hemant. Could you use a...
Okay, so these cells. So compared to the previous image, you can see these have a rounded contour, right?
Yes.
Whereas this one is more angulated, has very dense looking cytoplasm and larger nucleus. So again, similar to that of a parabasal cell, and there are some inflammatory cells in the background. So these are the metaplastic squamous cells. So before going to further pathological conditions, a short summary on the role of HPV. So as we already discussed, HPV goes and infects the basal layer of the squamous epithelium. On the left hand side here, you can see the normal maturation, right? So the basal cells mature upwards as they go and they become mature superficial squamous cells. Similarly, when the basal cells are infected, by a low risk human papilloma virus, the DNA of the virus stays outside the nucleus of the cell and it proliferates as the cell matures, does not integrate with the nucleus of the host cell. So there is normal maturation in a low grade lesion, whereas when there is infection by a high risk HPV, it integrates with the basal cell DNA and it prevents the normal maturation of cells and leads to uncontrolled proliferation and cancer. Like previously discussed, the E6 and E7 proteins are the major pathogenic proteins in HPV. Okay. So whatever cytological features we are going to look for in an abnormal squamous cell are the result of HPV infection in squamous cells. So now we can move to the squamous lesions.
One query from the chat box. Why do the cells stain differently? Some are orange and some are green and some are pink.
The PAP stain, it has a lot of different stains in it. The orangey, then there's I don't remember the other, the green stain.
Light green. That is light green. Light green.
Yeah, so this is based on the pH of the cells. The superficial cells are almost metabolically inactive, whereas the orangey stains more superficial cells which are metabolically inactive, whereas light green SF stains more the metabolically active intermediate cells. That is why we have some staining quality difference.
Also, the orange color of the superficial cells is because of keratin present in the cytoplasm of these cells. Yes. Whereas the intermediate cells, they have a cyanophilic cytoplasm, that is bluish green colored cytoplasm. And as you rightly said, under the influence of progesterone, so they are found in the progesteronic phase of the cycle, and they contain glycogen also in their cytoplasm. And especially in pregnancy, we have something called boat-shaped cells or navicular cells. These intermediate cells, their margins become folded and they become boat-shaped to accommodate all the glycogen in their cytoplasm. So we call those cells the navicular cells.
Can we continue, sir? Are there any more questions?
No, you can continue, Doctor.
Okay. So squamous lesions, we can have Dr. Shelley, Dr. Vinod, and Dr. Akanksha. And Dr. Shelley, are you?
32-year female, routine screening, thin prep, LBC.
Okay. So we'll start with this image. What is this cell?
Sir, this is intermediate cell.
Good. So this one?
This is superficial.
Right. So don't look at the cytoplasmic color. Look on the nucleus. Okay. So that is what we observe in this line. Now, do you want to describe this cluster? Okay. Now I'll point out the cells. You go one by one. Okay. So this cell.
Sir, this is intermediate squamous epithelial cell, but it is having high NC ratio.
Okay.
And the chromatin is fine chromatin, and the nuclear membrane is a bit irregular.
Okay.
And there is also a nucleoli in the center and lacy cytoplasm.
Okay. So one thing, those are not nucleoli, that's just clumped chromatin in the cells. And what about this cell?
So this is a binucleated cell.
Okay.
Binucleation we can see.
Okay. Then anything else can you make out? Anything like that?
Sir, it is having.
Just a minute. Why is this tree? The annotation is there. Just a
Maybe
minute.
you can click on the right, go back to the picture.
Yes, sir.
Right click and remove the annotation.
Just remove all the erase. Erase all.
Images.
But this shouldn't have happened. I do not know what's the reason for this.
Yeah, we can't see the images.
Yeah.
Okay.
I should come back now.
Yeah, that's fine.
Right. So can you make out a line around this nucleus?
Yes, sir.
This one, what is that?
Halo, perinuclear halo.
Or it's more of perinuclear vacuole, right? So what happens, we'll discuss this later. Then we'll go to the next slide. So these cells,
These cells are less mature than the previous slide and they are having high NC ratio.
okay, so those are, you're only seeing part of that cell, so we'll ignore that. So what about this? Just imagine this is the cell, okay? So this is the cell here. So what you are seeing is because these clusters are three-dimensional, so there is some overlapping of the cells. So you may not see the entire cytoplasm of these cells, okay? So here you can see this is the actual cell and this is the nucleus, okay? And what is this one?
Intermediate cell.
So that is your comparison, right?
Yes, sir.
So how, what do you think of this nucleus compared to this cell?
Sir, the nucleus is around more than 2 times of the nucleus of intermediate.
Right, so you compare the size of the nucleus with the size of an intermediate cell, right? Nucleus. And you can see this kind of notching in this nucleus, some nuclear membrane irregularity here. And again, you can see this notch in the membrane, right? Again here, this cell, the nucleus is enlarged. Similarly here, in this cell compared to this cell, there is nuclear enlargement and
nuclear group.
Binucleation.
So there is binucleation or probably an indentation, not sure. So this is from the textbook, very classical picture. So what is, this is what I was mentioning in the initial picture. What is this? The
Perinuclear vacuolation.
and what is it called?
Perinuclear halo.
Is that halo?
Halo.
Or
Coilocyte.
Coilocyte exchange.
right? So this vacuolation is called coilocytosis, and it is because of HPV infection. So this HPV infected, in a HPV infected cell, all the cytoplasmic contents, they are pushed to the periphery of the squamous cell, and the nucleus is surrounded by a vacuole-like structure which results in coilocytosis, right? So this is low-grade squamous intraepithelial lesion. So there are few features of an LSIL. The cells occur singly or in clusters, and they're usually confined to mature, intermediate, or superficial looking squamous cells. Why is that? Why don't you see that in parabasal cells?
Sir, because if we, sir, it is affecting the upper layer. If we go in HCl, then all the layers consecutively are affected. But here we see the changes only in the upper mature layers.
That is because it's mostly associated with the low risk HPV, right? Wherein the cell maturation is still there. The squamous cells are maturing and the virus travels with the squamous cell. That is why we see more of intermediate type squamous cells. And the very important criteria, the nuclear enlargement size should be more than 3 times the area of a normal intermediate nucleus in that slide. Okay, so the nuclear cytoplasmic ratio is little increased, but it's not very high NC ratio like you see in a high grade lesion where the nucleus occupies 70 to 80% of the cell, because both the cytoplasm and the nuclei enlarge in size. Okay, compared to a normal cell, they are increased, but the ratio is not that much increased. And these nuclei can be of variable shape. The chromatin can be granular or smudgy. Nuclear contours can be variable, can be smooth, can be very irregular, like notches, in which we like we saw in our images. And you can see binucleation or multinucleation. Okay. And this importance of coilocytosis is that it is not required for interpretation of LSIL. What is more important are the nuclear changes. Right? So what are the nuclear changes? Dr. Vinod?
Nuclear enlargement more than 3 times.
Yes, and the nuclear indentations, the chromatin changes, all those. So just because you have coilocytosis, that does not make it LSI. Okay. So that is what you need to remember. So as mentioned, like this cell, Dr. Akansha, you want to describe this cell? What do you think about this cell?
This cytoplasmic perinucleation is seen, perinuclear clearing is seen.
Okay.
Whereas the contour is not very irregular.
So you can see that the nuclear membrane is regular, the chromatin is regular. So this is called a pseudocoilocytosis, and this should not be interpreted as cell. You should always look for the corresponding nuclear features. There are certain mimics of L cell, which common ones could be a herpes infection where you can see multinucleation or radiation changes. So patients who receive radiotherapy for genitourinary cancer, for cervical cancer, when you take a smear from them, you can get changes like this. You see this markedly enlarged squamous cell. You can get these large nuclei. But what do you think about the NC ratio? So let's take this cell.
The NC ratio will be low in case of radiation.
Yes.
And it characteristically shows two-toned cytoplasm, and there's vacuolation also.
Okay.
And there will be no perinuclear clearing.
Okay, so perinuclear clearing may or may not be present, but the chromatin will be more smudged, and you won't see the nuclear features of an L cell. So that is more important. Okay. So any questions, any doubts so far?
There is a couple of doubts in the chat box. Why is the coilocytic change seen in the intermediate cells?
Yeah, so like I mentioned, they infect the basal cells, the HPV virus, but by the time the cytological manifestations manifest, the cell has already started maturing. So there is normal maturation going on along with the HPV proliferation. So by the time there's all the cytological or the nuclear features develop, the cell has reached its maturation. That's why you don't see the changes in a basal or a parabasal cell.
I think Dr. Namrata, that answers both your questions. So you can continue.
Okay. So images are not set. Okay. Dr. Vinod, we are coming back to the same image which we already discussed. Okay, we'll system. Yeah. So we are coming back to the same image which we saw. Dr. Vinod is there? Dr. Shelley?
Yes, sir.
Yeah. So what was this cell? What are these findings or the diagnosis of these cells?
In these cells, these are intermediate cells, but there is nuclear enlargement.
Yeah, so compared to this cell, it's a normal intermediate cell. How many times do you think it is enlarged?
It is about 2.5.
Let's say more than that, right? 3 to 4, 3.5 times.
More than 3 to 5.
Yeah, so this would qualify as, what would be the diagnosis? More than 3 times enlargement with some nuclear membrane irregularity.
Atypical squamous cells undetermined significance.
Why?
So because in LCL there will be nuclear enlargement less than 3 times of the normal intermediate squamous
More
cell.
than 3 times, no?
Yes, sir. I mean, in HCL there will be less than 3 times, but in ASCUS there will be more than 3 times. And we can see that.
You are confusing yourself just because you saw the next slide.
So in ASCUS, it is 2.5 to 3 times, and in LCL, it is more than 3 times.
Right. So more than 3 times is LCL.
LCL.
So just make this concept very clear. More than 3 times enlargement is LCL. Okay. So anything less than that would be, this is what we are going to discuss. Like this one. Okay, these cells. Wherein the nuclear enlargement, there is nuclear enlargement, right? You agree with that part of the cell? Or even you can take this one also. So there is nuclear enlargement, but it is not enough to qualify for a low-grade squamous lesion, right? So that is when we bring this category of atypical squamous cells of undetermined significance. Okay, so what would be this? So this has some criteria or scenarios where we get a diagnosis of ask us. So the nucleus is approximately 2.5 to 3 times, more than 3 times that of the background squamous cell, or twice the size of a metaplastic cell nucleus. Why twice in the metaplastic squamous cell? Because the nucleus is already larger, right? A slightly increased NC ratio. There is some hyperchromasia and irregularity, but it is not convincing for an L cell. Sometimes you can get orangophilic keratin cytoplasm, but the nucleus does not show all the features of L cell or the vacuole. So that is more also important. When you see the coilocytic vacuole, it should be complete and fully developed to call it as an L cell. Whereas if it is poorly developed, you only see part of a vacuole or some incomplete cytoplasmic clearing. Those are situations where you would call it as an ascus. Okay. So here you can see there is, can you see the mouse pointer? Is the mouse pointer visible?
Yes.
So can you use this to point the cell? Because images are disappearing if I use the pointer. So I can point the cells if anybody wants to just mention, I'll point the cells again. What about this cluster? You can see there is some nuclear enlargement and there is some nuclear membrane irregularity, but not enough to call it an L cell. Similarly here also, maybe this one cell is there with some kind of a vacuole, some nuclear enlargement, but not enough to qualify for an ascus. What about this one, Dr. Akanksha? What do you think about this image? What do you think of these squamous cells?
They are enlarged. The nucleus is enlarged to about 2.5 to 3.
Okay.
And then the NC ratio is not.
Okay, it's not very high.
There's a minimal hyperchromasia.
Okay. Are you seeing any nuclear membrane irregularity?
No, sir.
So I cannot see.
So no nuclear membrane irregularity, chromatinous fine, granular and dispersed uniformly. So there is just nuclear enlargement. If you take this as the normal squamous cell, there is some nuclear enlargement. Other than that, nothing else is there, right? So these are the perimenopausal cells or the PM cells. So you need to always look at the age of a patient when you are evaluating a smear, so that you can set the criteria for squamous lesions. Okay. So one more important factor about ascus is, unlike L cell, where you see a cell with a large nucleus 3 times, 4 times the size of a background cell, that cell becomes an L cell. Whereas ascus diagnosis is for a smear, it's not for a particular cell. So in a smear, when there are not enough cells to qualify as an L cell, the overall smear becomes the ascus diagnosis. So there may be a spectrum of nuclear enlargement, nuclear membrane irregularities, but none of these changes will reach the criteria for an L cell. Understand?
So that is Dr. Hemant, what he said is absolutely correct. Ascus and L cell both are both affect the intermediate cells, but when the L cell criteria is not met, that is qualitatively or quantitatively, the cells fall short of L cell, we put them in the category of ascus. And then as he described about coilocytes, now in coilocytes, he said there is perinuclear cavitation. So perinuclear cavitation, yes, it usually occupies more than 2/3 of the cytoplasm, and the cell outlines in a coilocyte are markedly thickened. They are, because of peripheral condensation of the cytoplasm, the cell margins are markedly thickened. The cavitation, the perinuclear cavitation or the perinuclear halo, we don't use the term halo usually for that. So it's a cavitation and it should occupy more than 2/3 of cytoplasm. And of course, mandatory that the accompanying nuclear changes should be there. And nuclear changes can be nuclear enlargement with chromatin abnormality, or you can even have a resinoid hyperchromatic shrunken nucleus. So two type of in a coilocyte, either nuclear enlargement or you can have a shrunken hyperchromatic resinoid nucleus also. So that also qualifies as a coilocyte. So anything short of this will go in the category. If it doesn't completely fulfill the criteria of coilocyte or other changes, then it goes in the category of ascus. So both are the lesions of intermediate squamous cells.
Thank you.
Please continue, Dr.
Yes, thank you. So now going to the next case, we know.
Yes.
Can you please read the history?
44-year female with discharge per vision.
Yeah. So what do you see in this? This cell, what do you think it is?
Parovism.
Right. So what about these cells? What do you think the difference is between these? This cell and this? I think you can move to a better image, this one. Can you describe this cluster?
Gland.
Why do you think it's glandular? You see something in between these cells here? Some junction-like things in between. So these are parabasal type cells, right? Smaller cells compared to this larger intermediate cell. But what about the nucleus? So let's take this as a normal cell, parabasal cell, and compared to this, what do you think is happening here? Nucleus is smaller, larger.
Nucleus is larger.
Yeah, so
nucleus
nucleus
is
is
larger side.
Okay, what do you think about the NC ratio?
High NC ratio.
Yes, NC ratio is very high. Compared to this cell, it's less than 50%. Almost 70-80% of the cell is occupied by this large nucleus. And
Yes,
what about the nucleus shape?
Yes.
Like this cell? There is some indentation, right?
Yes.
What about the chromatin?
Dense.
And more darker, coarse. You can see this.
Darker, dense.
Yeah, you can see this coarser granules of the chromatin.
Yes.
Okay. So Just a moment. Sorry. Yeah. Sorry. No, where the image is disappearing.
I think there's something in the, yeah, maybe you can share again. Maybe you can do one thing.
Yes,
Stop
sir.
sharing and share again the slides.
Okay, sir. Just a moment.
Just a second again. Yeah. I think we lost Sweetie. Sweetie is somewhere in the audience, but she's muted. Dr. Sweetie.
Is this visible now?
Yeah.
Again, it's.
I think there is something in your settings in your own laptop. When you copy paste, from somewhere else, sometimes it happens when you copy from your old document.
Maybe for these slides, you can just, without the full screen, you can just use.
You can do the small screen, yeah, like this.
Okay. So this one, Dr. Vinod, this cluster.
Yes, sir. The paravessel cells cluster, sir. This is the high ANC ratio.
Yeah.
The core chromatin.
Yes, and irregular nuclear membranes, right?
Irregular nuclear margin.
Okay. So about this one, we'll concentrate on this cluster.
High grade. Yes, sir.
Similar findings, right?
Similar paravessel.
Yeah. So, so what do you think about this cell, this orangeophilic cell? There is some vacuole around it. Will it qualify for what will it qualify for? There is some cytoplasmic orangophilia, some partial perinuclear habitation.
Perinuclear vacuolation.
Yeah, so what do you think it will qualify for? Will it be LCIL? So what about this cell? Large nucleus here. Maybe this would qualify, large nucleus like this one. It's missing part of cytoplasm. But here this cell you can see, an intermediate type cell with a very large nucleus. So this might qualify for an L cell, whereas this could qualify more for an ascus, right? Okay, so now this coming back to these clusters, this would be high-grade squamous intraepithelial lesion. So the cells of H cell are smaller, show less cytoplasmic maturity than L cell. Why is that?
Dysplasia.
Yes. Can you please repeat?
Dysplasia.
So what happens here is the virus integrates, the high-risk HPV DNA integrates with the host DNA and it prevents maturation of the squamous cells. Okay, so the cells no longer mature into intermediate type and superficial type cells. They just keep on proliferating and they start looking similar to parabasal type cells only. So that is the difference between L cell and H cell. Okay, the cytoplasmic maturity. So these cells can occur singly, sheets, or in syncytial aggregates when it is called as the hyperchromatic crowded groups, which has its own differential diagnosis, will be discussed later. And this sometimes they can look very small also, especially in liquid-based preparations. The H cell cells are very small. So you should always concentrate on any single small cell which is in the smear. And they are usually found in between the bigger clumps of cells. So you have to go very meticulously to identify a H cell. The nuclear contour is irregular, demonstrates prominent indentations or grooves. The cytoplasm is variable. It can be keratinized and orangeophilic or very lacy and delicate appearing also. So, Dr. Akanksha, imagine you are examining a smear, okay, and you find this type of cell. What do you think about this cell? This one.
This is high ANC ratio.
Yeah.
Irregular nuclear membrane, host
Yeah.
chromatin.
Okay. So now I tell you, this is the only cell which looks like this in the entire smear. Rest are all looking okay.
Normal.
So what will you call it as? 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 What will you call it as or the like this? Yes, yeah, like this cell.
Seems to be like HCl, sir.
ASCH.
Yeah, or like this, just this single cluster. So then the category of atypical squamous cells cannot exclude an H cell comes into play. So that is when the cells, these situation occurs when these abnormal cells are very sparse and they occur singly in small groups of less than 10 cells. When the NC ratio may look very close to a H cell, but it's more of a quantitative. Like you see very few squamous cells which are looking suspicious for a H cell, but it is not qualifying for a H cell, right? But Bethesda towards the last of ASCH says when you see a cluster of cells, when the nucleus is showing marked nuclear abnormality with high NC ratio, coarse chromatin, and even if it is few, it favors more of a H cell than a ASCH diagnosis. So it's a little subjective also, but it's this. So when you see very few cells, nuclear enlargement is that you are not convinced that it is reaching the criteria for H cell. So then you would use this criteria of atypical squamous cells, cannot exclude a H cell. Okay. Shelly then?
Yes, sir.
Yeah, you want to describe this one? This
Sir,
is from a 50 years female with bleeding per vagina.
Sir, in this cluster, we can see hyperkerato. The keratin is increased in the cells because it is orangiophilic, but the nucleus is intact. So it could be parakeratosis.
Okay. Do you think you will get so much clumping and hyperchromasia in parakeratosis? Okay, we'll put another picture. What about this one?
Sir, in the center, I can see a tadpole cell. Sir, all the cells, they are having, first of all, there are superficial squamous cells and intermediate squamous cells.
Okay.
And they are scattered, they are not in clusters.
Okay.
And all of the cells are having nuclear pleomorphism with irregular nuclear membrane, and nucleoli is also present.
Yes.
In the center, there are two tadpole cells.
Right. These ones, right?
Yes, sir.
Are they also called as what? Caudate cells. And you can see some spindle cells like this. Very abnormal looking nuclei, hyperchromasia. Anything in the background you wish to comment on?
Tumor diathesis.
What is tumor diathesis?
Sir, because it is a necrotic debris.
Yeah, like this. You can see this one. You can see this granular material in the background clinging to the cells, right?
Yes, sir.
So this is tumor diathesis. Again, coming here, what is this structure?
The pearl.
Yeah, so it's a squamous pearl. And here you can see a very abnormal looking squamous cells, right? Here, if you put everything together, very abnormal looking squamous cells, very keratinized appearance, squamous pearls, tumor diathesis,
Keratinizing squamous
cell carcinoma, right? When you put everything together, it becomes a squamous cell carcinoma. And here again, you can see this debris clinging to the cells. And why this is important is in LBP, most of the diathesis is removed by the preparation step itself. So you get very little diathesis in LBPs, and it becomes difficult to recognize invasive features. So you need to look very closely to the cells and see this debris clinging to the cells. Okay. Whereas if this is from a conventional smear, you can see a lot of debris in the background. And what do you think about this one, this cluster?
Here we can see a cluster, and sir, they are overlapping, and there is nuclear pleomorphism.
Yes.
And the nuclear membrane is irregular. There is high NC ratio.
Yeah.
There is presence of nucleoli.
Yeah. In the background?
In the background, there is inflammatory
cells and some necrotic debris also. So this is how a non-keratinizing squamous cell carcinoma would look. Okay, so the cells are much smaller and difficult to call squamous directly, right? Because it is more of the non-keratinizing type. So in squamous cell carcinoma, cells predominantly can occur as single cells or in cellular aggregates. Caudate and spindle cells can be seen, and the keratinizing type contains dense orangophilic cytoplasm. Marked nuclear variation will be there. You can see macronucleoli more in the non-keratinizing type. And a very important feature to look for is the tumor diathesis. Okay. I think we reached the end of squamous lesions. Are there any questions?
One related query was, when the smear is predominantly composed of orangophilic superficial cells and very much less intermediate cells, does this indicate anything in particular?
No, it is in any normal mature squamous epithelium, you can get a predominance of superficial type squamous cells. It doesn't have much significance. It's more in the proliferative phase where there's a lot of estrogen levels. It has no significance.
Charanjeet ma'am, any comments from you at this junction?
Actually, sometimes, if there are a lot of these nucleated, lot of these superficial squamous cells compressed together with an orangophilic cytoplasm, that's also called parakeratosis. Of course, as he said, as long as it's not an atypical parakeratosis showing nuclear enlargement or other features, normal parakeratosis can be seen in inflammatory conditions or in other benign conditions. So that could be parakeratosis also.
Yes.
If we see these clumps of orangophilic cells, superficial cells.
Thank you, ma'am. Thank you. You can continue.
Yeah. So now Dr. Jennifer will be continuing with the glandular lesions. I'll hand over to ma'am. Can you see this PPT?
Yes.
Yeah, just a minute.
So good evening, everyone. I hope all of you have had a good exposure now to the squamous part of the cervical cytology. Actually speaking, the squamous part is much, much more important for you to understand and recognize, especially the normal morphology, and then to go on to see the abnormal morphology in squamous epithelial cells. So glandular cells are actually a little more difficult to begin with, and quite often glandular cells, it's really not easy to see the chromatin pattern. It's not very often that we see distinct cells very clearly. So it's more about, getting your eyes trained to recognizing the architecture of these cells and the presence of these cells as crowded groups within the entire spectrum of the cells that you would see in any cervical smear. So most importantly, Bethesda says that cervical cytology is a screening test primarily for the detection of squamous cell carcinoma of cervix and its precursors. So it's not primarily a test for glandular cells. It's not a screening test for glandular abnormalities. It's a screening test for squamous abnormalities. So transformation zone, as Dr. Hemant very clearly explained, is not always necessary for an adequate specimen, but it's always reported because the presence of the transformation zone tells us that the examination is complete. So what does this complete transformation zone comprise? At least 10 well-preserved endocervical or squamous metaplastic cells which are present singly or in clusters. So what happens if there is insufficient endocervical or transition zone component in any smear? So if the patient is 30 years or older, we don't do this as a routine test in our country, though some of the centers have definitely started as HR, that is high-risk HPV testing is preferred. So if HR-HPV testing is not available or has not been performed, within 3 years, a repeat cytology is acceptable if transformation zone has not been sampled. If the patient is less than 30 years, even if the transformation zone has not been sampled, repeat is not required ahead of time. Routine screening is sufficient, and that is what is recommended by the American Society of Colposcopy and Cervical Pathology. So we'll start with case 1 Case 1, we will be actually starting again with normal morphology, and then we will go on to the glandular cell abnormalities. So once again, can I have Sweetie or Sajana or Raji? Who's that?
Yes, ma'am.
Yes.
So, Sweetie, shall we start with you? So, this is a 35-year-old lady, routine. Most of them come as routine, as Dr. Hemant said. But please note, LMP was 7 days ago, and she also has an intrauterine contraceptive device for the past 3 years. All right. So, now we are going to start with what you're seeing in low power. So, you can see all these cells in the background, which are all the squamous epithelial cells. What do you think these cells are? Do they look different from these other clusters?
Yes, ma'am. These are the honeycomb shaped clusters of cells. These are endocervical cells.
Yes, very good. So this is the slightly higher power of the same cluster. So like you rightly pointed out, this is the honeycomb pattern. So here you can see this pattern very clearly. So what do you mean by honeycomb pattern, Sweetie?
Ma'am, all are arranged in a honeycomb pattern with the clustering of cells.
Okay, so what is very clearly visible here is that it is monolayered, isn't it? There is really no overlapping.
Flat sheet of cells.
It is a flat sheet. Very good. And what are you seeing between the cells? What is that? Very distinctly, you're able to make
This vacuolate.
What is those lines that you see? What are those lines? I think you said it.
Cytoplasmic body.
Cytoplasmic membrane. So the cytoplasmic membranes are very clear, very well discerned. So you can see that it is a flat sheet. And do you think they look very dark, these nuclei, or are they light colored?
They're light colored.
Light colored, isn't it? So this is hypochromatic. The nuclei are relatively hypochromatic, and they are a flat sheet, monolayered, and you can see the cytoplasmic membrane very well discerned. So again, this part is showing you the honeycomb pattern. What is this part looking like? What pattern would you call this?
Picket fence appearance.
Fence appearance, very good. So
Side
what is
view, it can be seen. Side view.
Yes, side view. Okay, so what is this material here on top? Why is the nucleus pushed to the bottom? What kind of cells are endocervical cells to begin with?
Columnar.
Columnar cells, very good. So columnar cells have got, what is this thing? What's here?
Cilium.
Terminal plate. Tuft of cilia from there is tuft of cilia from terminal plate.
Mucin.
Talking about intracytoplasmic.
Mucin.
Mucin, yes, very good. So that is the mucin which is present there. So here again you can see that picket fence appearance, and the nucleus is pushed to the bottom because this part of the cell is occupied by mucin. So here the polarity is maintained with nucleus at the bottom and mucin at the top of the cell. So this is the picket fence appearance of these endocervical cells. Now again another sheet to show you. So here you can see the chromatin. What do you think the chromatin looks like, and what are those tiny, little darker things?
Granular, finely granular chromatin.
Finely granular chromatin. What do you think about the nuclear membrane? Is there any irregularity?
Oh, ma'am.
Yes. It is smooth nuclear contours, but there is some variation. There is mild variation and sometimes even marked variation in the size of the cells.
Vesicular nucleus.
Sorry?
Vesicular nucleus.
Vesicular
nucleus.
Yes, with fine chromatin, but there is variation in the size of the nuclei. But again, there is no overlapping. That is very important to note. There is no overlapping here, and the cell membranes are quite distinct. Okay, all right. So columnar epithelium with variable nuclear sizes, slightly larger, like Dr. Hemans pointed out, always the intermediate squamous cell nucleus serves as your baseline to compare the other cells with. So this is slightly larger than that of intermediate cell, and the chromatin is finely granular, evenly distributed, and small nucleoli. You could see those tiny pinpoint things there. So those are the small nucleoli which are seen in normal endocervical cells. And the cytoplasm can be diffusely vacuolated. Yeah, you can see that it almost looks empty, the cytoplasm. So that is because it's vacuolated, or it can be granular. And we saw how polarity is maintained, nucleus at one end and mucus at the other end. And you all very beautifully explained the picket fence and the honeycomb. And you need to remember that when it is from the upper part of the endocervical canal, the cells can very closely mimic squamous metaplastic cells. Quite often, we are unable to differentiate between the two. So sometimes these cells can even appear like this, very what we call as hypochromatic crowded groups. So it can look like a very thick hypochromatic fragment where you really cannot make out the hypochromasia or the finely granular chromatin, but you can only see that there is this pattern here. So sometimes this does get mistaken for glandular abnormality, but as much as possible towards the periphery of the groups, try to look at the chromatin, and then you will be able to discern that this is only a normal endocervical group. But this can throw us into a diagnostic dilemma sometimes. Now look at this sheet. So you can see, tell me about that cell. Are you able to see my pointer?
Yes, ma'am.
Yeah. So how will you the nucleus size compare this and this? Is there
It is
a difference?
enlarged with
It's
prominent
definitely
nuclei.
enlarged. Yeah, there is a nucleolus right there. But what about the chromatin?
Yes.
Rajiv, what do you think about the chromatin, Rajiv?
Hypochromasia, ma'am, is a spark.
Yeah, so it is still hypochromatic.
But and yes, ma'am, prominent nuclei is there, and the cytoplasm is there, and the nuclear counts regular.
Okay. Yeah, so there is enlargement, but you can see the nucleoli there, but the chromatin is still very fine. Again, here also, you can see that there is actually marked increase in nuclear size compared to this. Within the same sheet, you're seeing marked anisonucleosis within the same cluster. But again, please note that there is not much overlap. Some minimal overlap is happening here, but the chromatin remains fine and hypochromatic. What are all these other cells that you're seeing here?
These are intermediate.
I'm talking about these ones. I'm talking about these. Can you see my pointer?
Yes, ma'am. Yes, ma'am. This is a endocervical cells, ma'am. These all are.
Yeah, that's a sheet of endocervical cells. But what are these?
Polymorphs.
Ma'am, nuclei is there.
Neutrophils, they are the polymorphs. So you can see that there are polymorphs within this, and you can see that this sheet is showing marked anisonucleosis. And in the previous one, we saw that there was also some prominence of nucleoli. So this will fall under what kind of endocervical cells? What will you put them into? So this is reactive or repair. Okay, so this is the reactive or repair in endocervical cells. Textbook gives us very clear picture of, this is supposed to be the interdigitating school of fish appearance, or it is a mechanical pull apparently while processing. So the cytoplasmic appendages get pulled, and so that is called as a taffy pull appearance. So this is supposed to be the architecture of a reactive cervical group. We may not always see this architecture, but you can see again there are a lot of neutrophils in the background and also intracytoplasmic, and you can see that there are nucleoli which are very clearly visible within these clusters. So this is how you recognize endocervical cells which are showing reactive or repair features. So they are cohesive sheets that interdigitate in school of fish architecture with a taffy pull appearance. Cytoplasmic boundaries are well defined. That's what we saw. I'm sorry, I can't see the pictures now. Yeah, so we saw that the cytoplasmic, there is not much overlap. So each cell is distinct from the next one. So that is a very important feature. But the cytoplasm itself can show polychromasia, vacuolization, or perinuclear halos. And there is variable nuclear enlargement. They can be marked anisonucleosis within the same cluster. Typically, they are not overlapping. Outlines you all described very nicely that they are smoothly contoured. There is no irregularity of nuclear membrane. Again, you all talked about the vesicular chromatin and hypochromatic and uniformly finely granular chromatin. And we saw the presence of nucleoli. So this is how reactive endocervical cells will look. Now, Sajana,
Yes, ma'am.
I told you that she has had her LMP 7 days ago, isn't it? That was part of the history. So what do you think these clusters are?
Ma'am, these are the exodus ball. That is the endometrial cells.
Yes, very good. So these are the endometrial clusters. So what is most catching in this field? Here you can see all these squamous, but this endocervical is just standing out as a very dark looking cluster. So when you're looking at it under low power, that is what catches your attention. So there are these very tightly cohesive, dark looking cells, small clusters lying in the background. So that is what you need to pick up as endometrial cells. So is this normal, Sajana?
Yes, ma'am. Basically, it is seen during 6 to 10 days of the menstrual cycle, after 6 to 10 days of the menstrual cycle. So it is a normal finding.
Okay, so when will you get worried? In what age group will you get worried?
If
these cells...
after 45 years, if this type of cells are seen, that would be abnormal.
Yes, so you need to report it when you're seeing it in anybody who's more than 45 years, because up to that, it's reproductive age group and this is considered to be a normal finding. So in postmenopausal women, it is abnormal. So you need to report it in more than 45 years or older. Again, Bethesda reminds us that cervical cytology is not intended to screen for endometrial lesions and should not be actually used as a test of evaluation for suspected endometrial abnormalities. But we do see these often. When we see it, we need to report it. Okay. So again, you can again see that these are very dark clusters. So what kind of contour is this?
Outer one is the glandular one and the inner one is the stromal cells.
Okay, so inside this exodus ball, this is the stromal cells and you see a layer of glandular epithelium. This just looks very dark. You really cannot make out any glandular component or stromal component. Sometimes endometrial cells, this is all you can see in real life. When you're looking at it under the microscope, this is probably how much you can make out. What are these cells, Rajiv?
These are also endometrial clusters.
Are these endometrial cells?
Think,
Don't they look a
yes,
bit...
ma'am, slightly.
They are tall columnar cells, aren't they? You can't really make out very well, but there seems to be some mucin here and the nuclei are at the bottom.
Polarity, nucleus at one end and the mucin.
Yeah, so do you see mucin in endometrial cells? Which glandular cells will show mucin?
Endocervical.
I'm in the mid.
Endocervical.
Endocervical.
Actually a picket fence cluster of endocervical cells. So again, like Sajana described, so this is the exodus ball. So now these cells, if you have to look at the morphology and describe them, they're typically smaller than endocervical cells. You can see that they're much smaller. These cells are really small compared to the endocervical cells that we saw earlier. Normally, they have high NC ratio. So most of the cell is actually occupied by the nucleus. And the chromatin, you really can't make out much because it is dense and a heterogeneous chromatin normally. Nuclei are usually not seen but may be seen in LBC preparations. Mitosis are usually absent. Cytoplasm is scant, making the NC ratio high, and cell borders are not as well discerned as we saw in the honeycomb pattern of endocervical cells. You really can't make out cell borders clearly in endometrial cells. Now, when it is such a tight cluster, very often we might think that it looks abnormal because it looks really dark, isn't it? So then we start wondering if it is an epithelial abnormality. But small and the monotonous nuclear size should prevent us from overinterpreting it as squamous or as a glandular abnormality. These are some textbook pictures again to show you more of these tight clusters of endometrial cells. Here this is showing that there can be even apoptosis within the endometrial cells, because we have seen it all the time in the biopsies, isn't it? So endometrial cells can show apoptosis. So these are some of the textbook pictures again to show you the same. This is the exodus ball. Again, textbook picture this is stromal cells within, and there is a glandular layer around it. Okay, so this is the typical appearance of exodus ball. Now, sweetie, what cells are these? She's in reproductive age, right? She's also showing such cells. What cells are these? What is this arrow pointing to here? What are these things here? Anyone?
Cilia, terminal place cilia.
So these are actually cilia. Are they normally seen in endocervical cells, cilia?
No.
No. So what do you think this is?
Tubal metaplasia.
Metaplasia.
Excellent. So this is tubal metaplasia. So when we look at this cluster, actually it can look a little bit scary, isn't it? Because it looks crowded. Normally endocervical cells don't show that. So there is crowding, there is overlapping. The chromatin actually looks a bit coarse and it's dark, but you need to look for these cilia. So when you see these cilia, you need to realize that these are actually the normal cells which are just showing tubal metaplasia. What do you mean by tubal metaplasia? What tube are we talking about?
Fallopian tube.
Very good. So it is metaplastic epithelium that recapitulates that of the normal fallopian tube. So you can see ciliated cells, you can see peg cells, you can even see goblet cells. This is actually a textbook picture and that is supposed to be a goblet cell there. So you can see any of these types of cells. And this is one of the most common benign processes in the glandular component to be misinterpreted as endocervical atypia or as neoplasia. Like we saw in the previous one, there's enlarged nuclei, crowded nuclei, nuclear stratification, etc. can be seen, but the terminal bars and cilia will establish the benign interpretation. So that was tubal metaplasia. Now, Rajiv, I also mentioned that this patient has been on IUCD. She's been wearing a IUCD, intrauterine contraceptive device, for the past 3 years. I just want to remind you all of that history. And in that context, can you tell me what you're seeing here? What cells are these? Glandular cells or squamous cells?
These are glandular cells.
Yes, they are glandular cells. Okay.
Vacillation, cytoplasmic vacillation is there.
Yeah, there is so much of this vacillation. You're seeing, and then the nucleus is where?
Very hypochromatic is there and prominent nucleoli is there.
Yes, you're seeing prominence of nucleoli, good. And the nucleus is actually pushed to the periphery, isn't it? So there's a big vacuole here. Nucleus is pushed to the periphery. Nucleus has got nucleoli, and there is some some anisonucleosis also can be seen, and there are big vacuoles. So what does this cell actually remind you of? In histology, in histopathology, what cell would we call it?
Signet ring.
Very good. So this looks almost like a signet ring cell. So where do you see signet ring cells?
Adenocarcinomas.
No carcinomas, right? So this can be very well mistaken for adenocarcinoma. So, but in this patient, we are giving you the history that she's on IUCD. So when there is a history of IUCD and then you see these kind of vacuolated cells, be extremely cautious before interpreting it as an adenocarcinoma. Look at the nuclei. There is prominence of nucleoli. The chromatin is actually little bit coarse here, but overall it's not a very pleomorphic looking cell. So reactive cellular changes with IUCD can be seen in both endometrial and endocervical cells. They're usually single or in clusters. And note that the background will be clean. You might see only inflammation in the background. So you can have variable amount of cytoplasm with large vacuoles, and some cells may even show increased NC ratio. But the nuclear will show some degeneration with wrinkled chromatin or nuclear cracking, and again nucleoli will be prominent. So this is actually a very difficult area. So it is important that we get the history of IUCD, because otherwise it can be mistaken for adenocarcinoma of endometrium, fallopian tube or ovary, or a signet ring cell carcinoma. And when it is present single atypical cells with high NC ratio, sometimes it gets misinterpreted for head cell also. So you need to be extremely cautious before calling out adenocarcinoma in a patient with IUCD. If there is any doubt, you need to actually even consider recommending removal of IUCD followed by repeat smear. So these are some non-neoplastic findings which can pose great diagnostic difficulties in glandular epithelium. So we need to be aware of these differentials. Okay. So any doubts as of now?
A couple of doubts, ma'am. One, will these signet cells be PAS D negative?
Yes, they will be PAS D negative because the vacuolization is actually not caused by mucin. It is actually a reactive change. So they will probably be PAS D negative.
Another question I think you'll be coming up to is how to differentiate tubal metaplasia from an adenocarcinoma in situ with feathering.
Yes, we will come to that. Yeah, we will come to that in the later part of the presentation. All right. So, Rajiv, this is a 52-year-old lady. I'm giving you a history of vaginal hysterectomy. Okay, 3 years ago she's had hysterectomy. What are these cells? Are they squamous cells or glandular cells, or what are they? So if she's had, this is actually a vaginal smear. This is not a cervical smear, isn't it? She's had a hysterectomy, so it is a vaginal smear.
No, this is squam cells. So,
you're calling them as squamous cells?
Squamous cells, but nucleomegaly is there, ma'am.
Anyone else? Are you calling them as squamous cells, all of you?
Endocervical cells.
Yeah, these actually, you can't really call them definitely as endocervical, but yeah, yes, they are columnar cells falling more into endocervical cell category. Okay, so these are actually glandular cells. So she has actually had a hysterectomy. So you should really not be seeing glandular cells in a patient who's had a hysterectomy, isn't it? In a vaginal smear, you can only see squamous cells. So should you be worried? Sweetie, what do you think? Should you be worried? How can glandular cells come? You need to be worried, is it? Okay, but are you worried about the morphology of these cells? What is the chromatin looking like? Are you worried about the chromatin here? Are the nuclei, they're just hypochromatic, isn't it? Hypochromatic only. You can see one or two nucleoli.
Yes, ma'am.
Chromatin is actually fine. You're not seeing coarse chromatin. Okay. So this is an entity called glandular cells status post hysterectomy. So you can see benign appearing endocervical type glandular cells. Very rarely they might resemble endometrial cells also. They can even show goblet cell or mucinous metaplasia. And the presence of these cells should not be a concern for neoplasia. When you see these cells in a patient who is post hysterectomy, look at the nuclear morphology, look at the chromatin especially, and see whether it is finely granular chromatin, or are you seeing any coarseness of chromatin? Are the nuclei hypochromatic? Are they dark staining? Look at the NC ratio. These are some of the things you need to look at, and then you need to just satisfy yourselves because glandular cells can be present post-hysterectomy. They say that there are glandular cell nests or rests which can be found in the vaginal mucosa. So this is what leads to presence of glandular cells post-hysterectomy. So this is an entity we need to be aware of and not to get worried about. Can any of you tell me what you think this cluster is? There's a lot of inflammation in the background. This looks like a tightly cohesive dark staining cluster, right? This is textbook picture. This is not our case picture. Okay, so these are actually histiocytes. Okay, so this is also something you need to be careful about. Again, the differential becomes atypical endometrial cells. So these kind of clusters also can be present. For a novice pathologist, often they get mistaken for atypical endometrial cells. And again, what is this? This kind of cluster, a tight cluster. There is hardly any cytoplasm here. This is something called as naked nuclei. So this is a mimic of exfoliated endometrial cells. These can be seen in older age groups. So this again sometimes gets mistaken for endometrial cells and gets reported as presence of endometrial cells in a lady who is more than 45 years of age. But this complete absence of cytoplasm, but there will be also smooth nuclear contours, but some molding also can be present. This incident increases with age, but this should again not get mistaken for neoplasia. Having told you all of these, it is very difficult sometimes to exclude atypical endometrial cells in the context of naked nuclei and also with histiocytes. This is just for us to be aware that these are actually non-neoplastic findings which can fall into the differentials for atypical endometrial cells. Okay, so with that we come to the end of normal morphology and the slight variations from normal morphology and non-neoplastic findings. Now we will go on to epithelial cell abnormalities. Okay, so Saif, can you tell me, Saif, are you there? Yeah. Can you tell me, how do you list out glandular epithelial cell abnormalities?
We first see the nuclear size. There will be
Not asking you for the features, I'm asking you to list it out. What are the names of the entities?
Sorry, ma'am. It would be
How does Bethesda classify glandular epithelial cell abnormalities?
Yes, ma'am. Not otherwise specified, we have endocervical, endometrial, and endometrial and endocervical endometrial cells atypia. Then we have endocervical atypia favor of neoplasia. Then we have adenocarcinoma in situ, and then we have endocervical carcinoma.
Very good. So this is actually the classification. So there is, under the atypical criteria, we have the NOS, right? Endocervical, endometrial, and glandular. You just left out glandular, Dr. Saif. And you also have endocervical favor neoplastic, glandular favor neoplastic. Like you said, adenocarcinoma in situ, and then it goes on to adenocarcinoma, which can be endocervical, endometrial, sometimes extrauterine, like ovarian also gets exfoliated. We might see that also. And also sometimes we might say adenocarcinoma, not otherwise specified. Like, sometimes rectal adenocarcinomas, which are infiltrating, can also get exfoliated and come in the cervical smears. So this is actually the classification. Now, when we say atypical, we mean that it is more than benign, but not falling into the neoplastic category. In squamous, we saw an entity called as ascus, isn't it? But in glandular, they don't want to keep a category as agus or atypical glandular cells of uncertain significance. Such an entity does not exist under Bethesda for glandular epithelium because they feel that it might very often get confused with ascus. Okay. Another point to note here is that, see, this is endocervical NOS, endometrial NOS, glandular NOS. When you come to favor neoplastic, we are missing one category, isn't it? We are missing the endometrial category. Endometrial NOS is there. Endometrial favor neoplastic is not there, because it is very well recognized and understood that it is very difficult to further classify endometrial cells atypical as NOS or neoplastic, because most of the time this further classification on cervical cytology smears is not correlating with the biopsy outcome. So they feel that it is safer to leave endometrial as only NOS, not otherwise specified, and not to go into favor neoplastic or NOS as a further subclassification endometrial atypical cells. Another point to note is that we do not use the term favor reactive. We cannot call atypical endocervical cells favor reactive. That term also is discouraged, because Bethesda feels that if we say favor reactive, we don't know really. Sometimes we really can't make out. When we are seeing some atypia, we can only say NOS or neoplastic. When we say reactive, the clinician might ignore it and leave the patient alone. They don't want that to happen. Any kind of atypia, they want some follow-up to be there for the patient. So they do not recommend atypical endocervical cells favor reactive. Okay, so these are some points to note before we start the glandular epithelial cell abnormalities. So atypical endocervical cells, I already told you, more than normal, not sufficient to put into neoplastic category. And again, there is AEC NOS and AEC neoplastic. I'm just going to show you some textbook pictures now. First, let us remind ourselves of what reactive looks like. So reactive, you can see that the cells are very distinct from each other. Okay, they look actually pretty scary. If you look at it, it actually looks really scary. But you need to remember and look for the specific criteria. There is no overlapping. Well-defined cell borders are there. Prominent nucleoli are present, and the nuclear contours continue to be smooth. Okay, so even though there is so much of anisonucleosis, the well-defined cell borders and the chromatin is like that, and the prominence of nucleoli and the smoothness of nuclear contours should tell you that this is probably just a reactive phenomenon, especially with some neutrophils sitting there within the cytoplasm. Okay, so this is reactive endocervical cells. Now this is atypical endocervical cells, NOS. So here you can see that you can make out cell borders. There might be some minimal overlap. Okay, nuclear enlargement is there. NC ratio is increased. There is hyperchromasia, some mild nuclear membrane irregularities you can make out. So, but you cannot definitely say that this is neoplastic, because the chromatin still remains sort of fine. Okay, it's not really coarse chromatin. Now look at this. This is favor neoplastic. Why? Because there is definitely overlapping. This is actually a stratified strip. There is nuclear stratification. And you can see that the chromatin is definitely coarse. Okay. And here you can see some nuclear membrane irregularity. It is not really very prominently seen in this particular cluster. There is some nuclear membrane irregularity. And you can see that the NC ratio, if you look at individual cell, the NC ratio is markedly increased. And the nuclei definitely look dark as against the hypochromasia that you see in other kind of atypical endocervical cells. Okay. With that, we are going into the next case. So, in this particular case, we will cover the entire endocervical spectrum. Oh, no, not in this case. Yeah. Okay. So this case, Dr. Saif, will you actually describe this case for me? So she is a 45-year-old lady with abnormal uterine bleeding. That's the history we've got. Okay. So what do you see in the background? What are the predominant cells in the background?
Intermediate cells, ma'am, along with parameters.
You see squamous cells in the background, yes? And then you see some
clusters, ma'am.
Yeah, some clusters of cells you are able to make out here. Okay, they are a bit dark, isn't it? So these are actually looking dark clusters. Now, what do you think they are?
They have hyperchromatic nuclei.
Yes.
So overlapping.
Yes.
Then at the periphery, ma'am, they show the feathering.
Yeah, so what is that feathering? That is what you are seeing here, right? You're seeing some feathering in these clusters. Again, you can see that there is feathering in these clusters. Okay. And here you can see that it's actually forming something like asana pattern with the crowding. Okay. Again, these clusters are also showing you. So what is feathering, Saif?
Ma'am, equivalent of tumor diathesis, ma'am.
Sorry, I can't hear you very well. Could you please repeat that?
Ma'am, it is like a tumor diathesis, ma'am.
It's in tumor diathesis?
Nuclear protrusions along the periphery.
Yes, so it is cytoplasmic or nuclear protrusions or tags at the periphery which are standing out. So you can see that this is actually cytoplasmic or nuclear protrusion at the periphery. Okay. Again, you can see very nicely, you can see the protrusion at the periphery. So this is a very distinctive feature of what entity, Saif? What will be a diagnosis on this case?
Atypical endocervical cells favoring neoplasia.
Atypical endocervical cells favoring?
Neoplasia.
Neoplastic, okay. Dr. Ayushi or Dr. Pratik, would any of you like to give any other diagnosis for this case?
Can it be in situ adenocarcinoma in situ because of the SNI formation and feathering?
Yes, very good. So this is actually adenocarcinoma in situ. So when we were talking about atypical cells favor neoplastic, I did not mention feathering at all. Feathering is not a feature of atypical endocervical cells favor neoplastic. Feathering is a very distinctive and specific feature for adenocarcinoma in situ for endocervical cells. So this is endocervical adenocarcinoma in situ. And like you said clearly, this is actually protrusion of the cytoplasm and the nucleus, which can be seen in adenocarcinoma in situ. So there was a question previously about how do you differentiate it from tubal metaplasia, right? So in tubal metaplasia, we will not see these kind of things. What we are looking for in tubal metaplasia is actually cilia. We are not looking for cytoplasmic protrusion. Okay, so cytoplasmic and nuclear protrusion will not happen in tubal metaplasia like the picture that I had shown earlier. If you want for further clarification, I can go back to that picture. So that will actually show cilia and terminal bodies and terminal bars and not cytoplasmic protrusion. So that is the difference between tubal metaplasia and this. So cilia will be much finer. This will be, actually you can see that it is the same color. In this particular thing, you can't really make out much cytoplasm at all, but it will look the same color and the, you know, the density of the cytoplasm will be the same as what you see in this cytoplasmic protrusion that you're seeing here at feathering. So this is endocervical adenocarcinoma in situ. So there is nuclear enlargement, hyperchromasia, chromatin abnormality, pseudostratification and mitotic activity also can be seen. And up to half of AIS lesions will have a coexisting squamous intraepithelial lesion also, usually of high grade, because they are all HPV related. The HPV dependent ones will also show a coexisting squamous intraepithelial lesion. So this is a very crowded slide. So cells will occur in sheets, clusters, pseudostratified strips or rosettes. So this is actually a, oh sorry, I can't get the pictures again. Yeah, this is actually what they call as a rosette pattern. So that is the appearance of the cells. There will be nuclear crowding and overlap, loss of a well-defined honeycomb pattern. And this is the palisading nuclear arrangement with nuclei and cytoplasmic tags protruding from the periphery, which is the feathering, which is a very important feature to note. And then there will be increase in NC ratio. Nuclei can be oval or elongated. Nuclear hyperchromasia, coarsely granular chromatin, nucleoli are inconspicuous. Background is clean. You might see abnormal squamous cells if there is a coexisting squamous epithelial lesion. So what is the significance of reporting AIS? So when we call something as AIS, according to the ASCCP guidelines, colposcopy and endocervical sampling has to be done. But if the patient is more than 35 years of age, endometrial sampling also should be done. And when you do an initial biopsy, if there is no evidence of invasive disease, diagnostic excision has to be done. If it is present on the biopsy also, the final outcome will be total hysterectomy, unless they want to do a conservative management. If conservative, you can do an excisional procedure like LEAP margin evaluation. So that is the significance of reporting AIS. Okay. Now, going to case 4, Dr. Ayushi, will you present this, please? This is a 65-year-old lady with 2 episodes of postmenopausal bleeding. So in this particular case, there'll be the entire spectrum of endocervical cells, beginning from benign right up to the highest grade of the endocervical abnormality. Okay. So you need to look for all the features. Ayushi?
She is a honeycomb pattern of endocervical cells.
Very good. So this is a benign honeycomb pattern. Okay, here again you're seeing the benign honeycomb pattern, but what about this one?
There is overlapping and crowding at
Crowding
places.
is definitely there. So there is some, you're beginning to feel that there is some atypia there. What about this cluster?
There is again there is overlapping and overcrowding. There is a loss of
What do you think about the chromatin here?
It is fine. It is
Fine
hypertonic.
chromatin. What about the nuclear contours?
Regular.
Regular and smooth. What do you see there? What am I pointing to?
Granular, the chromocenters. Nucleoli.
Nucleoli you're seeing there, right? And what are these cells which are admixed with these endocervical cells?
Polymorphs, no?
Polymorphs. Okay, that's right. So what do you want to call this sheet?
Reactive.
Reactive endocervical cells. Very good. So you're seeing reactive endocervical epithelium also. Now come to this one. Compare that and this. Here, there was not much crowding or overlapping, but here there is
crowding and overlapping.
Crowding and overlapping. Okay. But what about the chromatin? It is still fine. Sorry. Actually, when you look at endocervical or endometrial cells, often you'll have to use the fine adjustment to be able to see the chromatin clearly, because they are very crowded, and when they are crowded and overlapped especially, because you need to be able to see through to see the nuclei. So you will have to use in real life a lot of your fine adjustment to see through to the chromatin. Okay, so here again it's not dark, it's still light colored chromatin. That much you can make out in this cluster, isn't it? Yeah, it's not very dark, but it's crowded. So this will fall under these clusters. This also, these kind of clusters will fall under
atypical glandular cells, NOS.
NOS. Very good. So this is atypical endocervical NOS. Okay. Now here it is getting little more darker, isn't it?
Yes.
So you can see that it's crowded, it's darker. Okay, here also. Here you're seeing a benign looking sheet.
Yes.
But right here you're seeing some crowding. This is the cluster which is very much crowded. Here, but at the periphery you can make out the chromatin. Isn't it? You can make out some chromatin here, you can make out chromatin here, and you can see that it is still not that coarse. It is still finely granular chromatin. So this will also fall under atypical NOS. Now what about these clusters?
Overcrowded, there is overlapping, there is feathering in the periphery.
Okay, very good. And the chromatin is getting a bit more coarse, isn't it? It's becoming a little coarse chromatin. Here again you can see that the chromatin is definitely coarse here. Okay, and there is crowding, and this is almost like an asana formation that is happening here. Again, a crowded cluster, coarseness of chromatin, which you can see in that periphery. Here you can nicely see the coarseness of the chromatin. Okay, so this you need to really look at the periphery to be able to see the chromatin, because in the center it will all be very crowded and you will not be able to see the chromatin. So you need to go to the cells at the periphery to see the chromatin. So you can definitely see the coarseness of chromatin here. So this will become atypical, favor
Neoplastic.
Neoplastic. So again, definitely you're seeing some asana pattern here, and you're seeing the cells with coarse chromatin. favor neoplastic. Okay. Now, what is this thing that you're noting here?
Cytoplasmic tails.
Yeah, so you're beginning to see some protrusions, some tags. You're beginning to see some tags here, right? You're able to see nice tags here. Okay, so what will you call this?
Feathering.
Yes, feathering. So what criteria will, what classification will this fall under?
In situ, adenocarcinoma in situ.
Adenocarcinoma in situ. So you can see the nice cytoplasmic tags here, right? So this is adenocarcinoma in situ, and you can see the very crowded clusters, and you can see the coarseness of chromatin in the periphery of these clusters. So this is adenocarcinoma in situ. This is also showing the cytoplasmic tags, sort of an asana pattern there, and coarseness of chromatin. So this is adenocarcinoma in situ. Even this cell is actually abnormal. This cell is also abnormal. You can see the chromatin that is coarse. You can see that the NC ratio is markedly increased, isn't it? Hardly any cytoplasm. So normal endocervical cells should have a lot of cytoplasm. So here you can see that the NC ratio is markedly increased. Are you able to make out any cell borders, Ayushi?
No, there is loss of defined cytoplasmic margins.
Yes, so there is loss of the cytoplasmic margin. So it is a where the architecture is lost. You're not seeing that well-defined cytoplasmic borders anymore. What do you think this background looks like?
Necrotic debris.
There is
Inflammatory cells.
yes, so it is looking like a dirty background. There seems to be some debris, and there are these some cohesive clusters that you are seeing here, right? So the background is actually very dirty. There must be some necrotic material there, some debris is lying there, and you're seeing some dark looking clusters here and there. What do you think these cells look like?
There is tumor diastasis in the periphery. There is overlapping, overcrowding.
What is this actually? So this is the
Tumor diastasis.
what is tumor diathesis, Ayushi?
The necrosis of the cells.
Okay. Admixed with?
Inflammatory cells.
Admixed with inflammatory cells, and it is usually just sort of clinging to the cluster. So it is actually, this is all LBC. So you see what is called as clinging diathesis here. So you can see the debris with inflammatory cells and clinging diathesis. And here you can see that the cells are looking little more pleomorphic also. Here you can see this is again the diathesis, right? So you can see the cell is also actually not very well preserved. It's almost looking like it's going to die. Okay, it's not very well preserved cell, but you can see that it's got irregularity of nuclear membrane. Definitely it's a neoplastic cell, and it's lying within what looks like necrotic debris and inflammatory cells. So here what do you see, Ayushi? Can you describe the cells that you're seeing here?
So moderately pleomorphic cells within large nuclei, oval to round to oval nuclei, and the chromatin is coarsely granular. There is conspicuous nuclei.
Yes.
And their cytoplasmic the margins they are lost.
Yes, very good. And you're also seeing some nuclear
irregularity.
Some irregularity of the nuclear membrane also can be made out. So, what do you want to call this finally?
Adenocarcinoma, endocervical adenocarcinoma.
Cervical adenocarcinoma. Okay. So, endocervical adenocarcinoma, you'll have a lot of abnormal cells. They will be present as single cells, two-dimensional sheets, three-dimensional clusters, or essential aggregates. And we saw this enlarged pleomorphic nuclei with irregular chromatin clearing, nuclear membrane irregularities. Macronucleoli also can be found. I'm sorry, none of my pictures actually showed that, but macronucleoli can be found. Cytoplasm can be vacuolated. Tumor diathesis is commonly seen, and quite often it coexists with a high-grade squamous lesion also. So you might see abnormal squamous cells also. So at this point, doubts?
How to differentiate school of fish appearance in the glandular cells with metaplastic squamous cells?
Okay, so school of fish appearance in glandular cells is what we see usually in reactive endocervical cells. So school of fish is actually an interdigitating appearance, and you will see that the cytoplasm also looks a bit pulled. Should I go back to that picture? Shall I go back to that picture?
Yes, ma'am.
So this is actually the school of fish appearance as described in the textbook. And so this is the interdigitating. So the cytoplasm is actually interdigitating, giving the school of fish appearance. But these are actually reactive cells. So we need to look for features of reactive cells, one of which is actually the presence of nucleoli. So you can definitely see that there is nucleoli present in these cells. And also you will see that these cells are admixed with neutrophils. So that is another feature which points to the reactive nature of this entire sheet. And if you look at metaplastic squamous cells, they are usually called as spider cells because the cytoplasm, each cell side, here you can see that it's only bipolar. I mean, on two sides the cytoplasm is pulled, whereas the spider cells will be actually looking like they will have, the cytoplasm will be extended on multiple sides. Okay. And if you look at LBC, metaplastic cells actually look much more rounded. In conventional, they've got the spider cell appearance. In LBC, they will have actually a rounded appearance, whereas these cells will show cytoplasmic appendage pulling only to the two ends, not on all sides. And you will also see presence of nucleoli and inflammatory background.
Thank you, ma'am. Thank you. You can continue.
Okay. Okay, so that finishes endocervical adenocarcinoma. Now going to the last case, which is actually 58-year-old lady with post-menopausal spotting. Dr. Pratik,
Yes, ma'am.
would you like to take this case?
Yes, ma'am.
Oh, sorry, I need to go full screen. Yeah. Okay, so this is a LOPA picture. So what is catching your attention?
Ma'am, there are atypical squamous cells are there, ma'am.
Okay, you want to call them straight away as squamous cells at low power?
No, ma'am. No, there seems like a cluster of cells.
Yeah, there are several tightly cohesive dark staining clusters that you can see. That is what is catching your attention in low power. Okay. Now, what do you think this sheet of cells is? Are these endocervical or endometrial cells?
Ma'am, endocervical, ma'am.
Very good. So these are actually endocervical cells. And here you're seeing that morphology is not at all clear. It is just showing an asana pattern there and some crowded cells are present. So you can see this is looking like a nice sheet of endocervical cells. Maybe it's reactive, we don't know. But this one, there seems to be some atypia, isn't it? Because it's a bit crowded and dark and there's an asana pattern seen there. Okay. What are these cells, Dr. Pratik?
These are, ma'am, endometrial cells, ma'am.
Very good. Why do you want to call them endometrial cells?
Ma'am, they have a central stroma and peripheral, central stroma and peripheral glandular platinum.
Okay, so they're actually a ball-like cluster.
Yes.
Or a tightly cohesive cluster. And is it as large as those endocervical sheets?
No.
They're usually smaller, tightly cohesive clusters of cells. Okay. But are they normal?
No, ma'am, no, they're not normal. They have an isonucleosis and hyperchromatic nucleoli.
Okay.
Mild overlapping is also seen.
Yes.
And irregular cell borders are there, ma'am.
Okay, so when we looked at normal endometrial cells, we said that they're usually small cells. Nuclear size will be very small. Okay, but here you can see that there is definitely nuclear size is enlarged. Okay, so that is the most important thing that you need to note when it comes to endometrial cells. The most important feature of distinction is that the nuclear size is enlarged compared to normal endometrial cells, and also chromatin already in endometrial cells is a bit dense. Okay, it's usually dark. The clusters are usually dark. But here you can see that there is a abnormal architecture also that is present, and the nuclear size is also increased. So those are important features to note. Here again, you can see that there is definitely increase in nuclear size in these clusters. So this is about atypical endometrial cells. Most important point of distinction is that the nuclear size is increased. But like I said before, we do not qualify as neoplastic or as NOS because this is very difficult to differentiate and it's poorly reproducible. When we say atypical endometrial cells, it could be endometrial polyp, it could be endometritis, it could be presence of intrauterine device, it could be endometrial hyperplasia, or endometrial carcinoma. So very clearly, cervical pap smear is not the diagnostic test to identify endometrial lesion. So when you're suspecting an endometrial lesion, it might be picked up on the pap smear, but it is always the final diagnosis is only on biopsy. Okay, so biopsy becomes essential even when you call something as atypical endometrial cells. So they occur as small crowded groups. Nuclei are slightly enlarged compared to normal endometrial cells. As the grade of the tumor increases, the nuclear size keeps increasing. Hyperchromasia, chromatin heterogeneity, small nucleoli, scant cytoplasm which may be vacuolated, cell borders are ill-defined. In LBC, even the shed endometrial cells may appear abnormal, showing greater pleomorphism of size and shape. So sometimes even the normal shed endometrial cells get reported as atypical endometrial cells on LBC. So now look at this picture. What do you see here? What is this in the background?
It's a dirty background, ma'am.
Yeah, some degenerate material is present in the background. And then there are, what are these?
It's a cluster of cells, cohesive clusters of cells.
Okay. Yeah, now can you describe these cells?
Ma'am, these are their cohesive cells showing high NC ratio in large nucleus with hyperchromatic nuclei fused with their prominent nuclei as well and cytoplasm, so vacuolations.
So there is nice cytoplasmic vacuolation which you can see here. What is this?
This mitosis.
Yes, so there is even a mitotic figure that is seen here. And you can see that there is prominence of nucleoli. And like I told you earlier, yeah, nucleoli will be present and it comes later. I'm sorry, I'll tell you that the nucleoli are present, but the size of the nucleoli keeps increasing with the higher grade of the tumor. Okay, sometimes they may be very small nucleoli in well-differentiated tumors. As the grade of the tumor increases, nucleoli can be seen as more prominent features. Okay, so this is definitely a mitotic figure, vacuolation, and definitely abnormal looking endometrial cells. Again, what do you see here? This is a small low power view. This is a higher power view of the same cluster. What is catching your attention is what is this?
More prominent vacuolations and the multiple prominent nuclei as well.
Prominent nucleoli are there, and you can see that the chromatin not very clearly seen, but there is coarseness of chromatin also. Here again, you can see that there is vacuolation, prominence of nucleoli. So here also, what do you see? What kind of a pattern are you seeing here?
I see now pattern, ma'am.
Sorry. Oh. Yeah, so you're seeing an acina pattern and there is prominence of nucleoli also which you're seeing here. Again, sort of similar thing, but what is different here? What is inside all these cells?
Neutrophils.
Yes, very good. So is there any specific name for this appearance, Pratik?
A bag of polyps.
Very good. So that is a bag of polyps. So this is a very classical feature of endometrial adenocarcinomas where you see vacuolated cytoplasm filled with neutrophils. So it is called as bag of polyps appearance. Okay, so you can see all these cells have got lot of neutrophils within the cytoplasm and they are big cells with big nuclei and big nucleoli. So they are clearly atypical endometrial cells which are showing bag of poly appearance. Again, you can see atypical endometrial cells and there is the bag of poly appearance which is quite a characteristic feature of endometrial adenocarcinoma. So the diagnosis, I've said it already, Prateek. So do you agree with me?
Yes, ma'am.
So this is an endometrial adenocarcinoma. So cells occur singly or in small tight clusters. In well-differentiated tumors, nuclei may be slightly enlarged and they increase with, get larger with increasing grade. Nuclear size variation, loss of polarity, hyperchromasia, irregular chromatin, chromatin clearing, particularly in high-grade tumors. Small to prominent nucleoli, like I said, nucleoli become larger and larger with higher grade of tumor. Cytoplasm is scant, cyanophilic, often vacuolated. So the bag of poly appearance is often seen. Grade 1 tumors look almost like, just look like abnormal cells, shed cells with minimal atypia. They get interpreted as atypical endometrial cells. Now you need to remember that endocervical tumors, we will often see lots and lots of atypical cells because you're directly sampling the cervix. Whereas endometrial atypical cells often will be very few here and there because they are actually exfoliated from the endometrium. You're not directly sampling them. So exfoliated neoplastic endometrial cells are usually fewer compared to endocervical cancers. And the cells are usually smaller with smaller nuclear area. Tumor diathesis is usually watery or just finely granular. So that is about endometrial adenocarcinomas. This table is straight out of textbook. You can look at it in your books also. Comparison between endocervical and endometrial carcinoma. Hypercellular, low cellularity because this is exfoliated cells. Strips, rosettes, sheets with feathering or single cells. Here they're small clusters, very rarely papillae or single cells. Diathesis, usually it is visible. Here it is variable and watery, subtle, sometimes even absent. Cell shapes, oval, columnar, pleomorphic. Here they are round cells. Even the very pleomorphic cells are actually round with irregular appearance sometimes, but they're usually smaller. Nuclei will be oval, elongated, pleomorphic, vesicular. Here nuclei, as the grade goes higher, it becomes higher grade looking. Mucin will be present here. Here vacuoles will be present. Associated squamous lesion will be present usually in endocervical, not seen in endometrial, again because endocervical ones are HPV dependent tumors can be present. High risk HPV is positive and most negative. P16 because of the HPV positivity will be block positive, which can be done on cell blocks which can be prepared from the LBC sample. So the remaining LBC sample can be even converted into cell block and P16 can be done. It will be block positive in endocervicals and maybe patchy positive in endometrials. One last thing, we left out atypical glandular cells. So when do we call something as atypical glandular cells? When you cannot definitely assign it as endocervical or endometrial. But quite often, head cell involving glands gets reported as atypical glandular cells. So they will be tightly packed cells with high NC ratios, hyperchromatic nuclei and coarsely granular chromatin. But very often, head cell involving endocervical glands may be reported as atypical glandular cells. Now look at all these pictures. Looks like there's a lot of cytoplasm. I'm not sure, is this endometrial or endocervical? I'm really not sure. I might want to call this endometrial. You might want to call it endocervical. So when we are in such a scenario, whether we are not sure whether it's endometrial or endocervical, now the architecture looks like it could be endometrial, but you can see that the cells are actually separate distinct from each other. There's more cytoplasm around the cells. So I'm not sure these are endometrial or endocervical cells. Again, cells like these. When I look at this, I even wonder, is this actually head cell that I'm looking at? Or is it glandular cells that I'm looking at? I'm really not sure. So I might report these as atypical glandular cells. So these are some things which can be reported as atypical glandular cells. They turn out to be high-grade lesions 10 to 40% of the time, and they're more often squamous than glandular. And head cell frequently coexists with this. So when you call something as atypical glandular cells, again they'll do colposcopy with endocervical sampling. If more than 35 years, endometrial sampling also will be done. But when you call something as atypical glandular cells, repeat cytology is not an option. Waiting and repeating is not an option because when you call something atypical glandular, it is categorized as a high risk lesion. Okay, so with that, we come to the end of almost to the end of the session and definitely to the end of glandular cell abnormalities. Any questions?
One query is, why do squamous metaplastic cells have angulated cytoplasm?
I'm not really sure why they have angulated cytoplasm.
Charanjeet ma'am, would you like to take on that?
I also can't think of a reason why they have an angulated cytoplasm. So.
Then we'll go into the answers. I think one more query, sorry, I left out, was when you're discussing about histiocytes, the query was, do we tend to see epithelioid cells in the PAPs?
No, they're not epithelioid cells. If at all anything, they are tiny cells and their nuclei will be indented. So that is what gives a clue that these are actually histiocytes. Nuclei will be indented, but they'll be tightly cohesive. There won't be as much cytoplasm as in an epithelioid histiocytes. So we don't see epithelioid cells in cervical smears.
And also related to the IUCD query was how, after how much time of the IUCD removal should somebody repeat a pap smear, because IUCD changes can be alarming. So after the removal of IUCD, when should the pap be repeated?
I'm not sure again about that. Dr. Charanjeet, would you like to?
I think I have not read it, but I think the interval should be the usual interval that we can do depending on the age of the patient, the one that is recommended by WHO. After, the usual recommended interval can be done because we already know there's an history of IUCD.
Yeah,
yes,
so
if you are thinking there is a with IUCD, the patient also has a coexisting high grade lesion.
yes.
There's also an existing lesion is there. Then it becomes a difficult, a different situation. So probably there is no such recommendation given in Bethesda for such a situation.
No, it's not really recommended in Bethesda. So not very sure. Maybe the clinicians might have the answer for this, not sure.
One more query is, can giant cells be seen in pap smears?
Yes, we will come to that actually as a part of these pre-test answers.
And how to confirm the signaturing cell from the differential in cervical pap? Dr. Shankar, can you rephrase your question? Because how to confirm signaturing cell from the differentials is what she has posed.
So it is actually a difficult question. So that is why IUCD, when you're really suspecting that there could be a malignancy, it is better to remove the IUCD and then repeat the test. Again, sorry, we don't know what the interval should be, but how do you differentiate? Okay, so signaturing cells and these cells, the IUCD cells are supposed to have, the nuclei is supposed to have a degenerate or a wrinkled appearance. So that is what should give the clue that this is not really atypical glandular cells. They are just cells because the reactive change due to IUCD.
Also, the pictures that we saw in IUCD, the cells that resemble signaturing cells in IUCD, if you look at their nucleus, the nucleus was nice round nucleus in most of the cells. Whereas if they're actual signaturing cells, in signaturing cells, you have a huge mucin vacuole pushing the nucleus to the periphery and the nucleus is compressed out.
Yes.
So that was not the type of nucleus that we saw in the IUCD slides.
Yes, exactly.
Thank you,
thank you, Dr. Charanjeet. That is exactly the explanation for that.
Again, queries related to the follow-up. Again, after how many days for a follow-up for an ascus, the PAP has to be repeated. If I may, I think it's the ACOG guidelines give related to each of these categories, and the guidelines, current guidelines, have to be followed.
Yeah. They say that if you have ascus or any of these squamous lesions, HR-HPV testing is recommended.
Reflex.
Yeah. So that is the current recommendation. But if we are unable to do HR-HPV, the smear has to be repeated within 3 years for ascus, if I remember right. But it's best that you look up the guidelines given by ASCCP.
I think those are the queries, ma'am, and I think you can go to the answers for.
Okay. So first one, the answer is Trichomonas vaginalis. So these were some of the pictures that you saw. So that is actually the Trichomonas there. You can see that it is pear-shaped and there is the nucleus. Again, trichomonas here. This is what they look like. So they are pear-shaped, oval around, cyanophilic. Nucleus is pale, vesicular, eccentrically located. One important thing is leptothrix can be associated with trichomonas. So when you see these long structures, don't mistake them for candida. In a smear which has got trichomonas, these are actually good pictures, textbook pictures of trichomonas. This is. So these are actually what we see in real life. And these are good textbook pictures to show you the pear-shaped organisms with that eccentric nuclei, and leptothrix may be associated with trichomonas. Sometimes they may show granularity in the cytoplasm. That also is a feature of trichomonas. And mature squamous cells will show perinuclear halo, that is called as the trike change. So this is actually the perinuclear halo. You can see a faint halo. Should not mistake this for coelocytes, because if it is a coelocyte, there will be margination and the cytoplasmic rim will be thickened. The thickening of the cytoplasmic rim will not be seen in perinuclear halo of trike change. And lot of neutrophils also can be present in the background, which is also a feature of Trichomonas vaginalis. So the first potter was TV. Second one is Exodus ball. This was discussed during the presentation itself, so I'm not going into that. Third one is candidiasis. So candidiasis, you can see these are actually the pseudohyphae. Pseudohyphae of candidiasis can be seen here. And in this picture, you can see the spores. So these are the spores of candidiasis. So spores and pseudohyphae. So here again, you can see the spores here. These are the spores and these are the pseudohyphae. So they're typically budding yeasts or pseudohyphae. Pseudohyphae are formed by cytoplasmic extension of the budding yeast. And so they lack true septations, but will show complete constrictions along their length. So the constriction that you see is not really septation. Sorry, I lost the picture again. So you can see constrictions, but not septations in Candida. And this is called as a shish kebab appearance, where this is textbook picture, where a group of squamous cells gets peered through by the Candida, giving a shish kebab appearance. Here this textbook picture shows very clearly spores, and you can see the pseudohyphae. So that was candidiasis. Fourth case was Hetzel. Dr. Hemant had discussed it during the, Hetzel was discussed in detail, so I'm not going into that. Fifth case was actinomycosis. So actinomycosis, you can see that this is actually called as a
Funny ball.
Cotton ball.
Cotton ball, yes. Cotton ball appearance. So you have this cotton ball appearance or a woolly body appearance. So when it is tangled clumps, it is called as cotton ball appearance. Sometimes you might have radiating filaments, then it gives a woolly body appearance. So masses of leukocytes will also be adherent and they can be clubs seen at the periphery. But this is the typical appearance. So in which situation do you commonly encounter actinomyces in the cervical smear?
IUCD.
IUCD. So is it something alarming? Presence of actinomyces? Do you need to act upon it? Does the clinician need to act upon it? Not necessarily, unless it progresses to PID, to pelvic inflammatory disease. So actinomyces can be seen, and especially in patients with IUCD, and it's not alarming. Nothing needs to be really done about it. Next one was adenocarcinoma in situ. Again, it was discussed during the session. I'm not going into that. The next one is herpes simplex virus. So this is actually the typical appearance of herpes simplex. So someone had asked a question about multinucleated cells. Can they be seen in cervical smears? So multinucleated cells that are usually seen are multinucleated endocervical cells, multinucleated histiocytes can be seen, and syncytial trophoblast cells can also be seen. So when it comes to multinucleation, these are the differentials. Multinucleated endocervical cells, multinucleated histiocytes, and syncytial trophoblast cells can be seen in cervical smear. So how do you identify that it is herpes simplex virus? There are 3 M's that are seen in HSV. What are the 3 M's? Can anyone tell me?
Multinucleation, molding, and margination.
Excellent. So multinucleation, molding, and margination. What is the margination due to? What is getting marginated?
Due to
The nuclear inclusion, the chromatin is marginated.
Because what is filling up that space?
Virus.
Nuclear.
Very good. So the chromatin is getting marginated because the virus is actually filling up that place. Okay. So this is actually the multinucleated this is a textbook picture. So these inclusions, what are these inclusions called?
Cowdry type
Cowdry A type of inclusion. These are actually the Cowdry A type of inclusions which are seen in HSV. And HSV sometimes can be mononucleate. It need not be as multinucleated as this. Then it becomes a close differential for squamous intraepithelial lesion. Okay, it can become a differential for L-cell or H-cell. So how do you differentiate? You have to distinguish the intranuclear herpetic inclusion from the hyperchromatic chromatin of cell, that is squamous intraepithelial lesion. So you need to look at the chromatin. Here, how is it? It has got the ground glass appearance, isn't it? Because of the margination. So that appearance will not be seen in L cell or in H cell. The chromatin actually there will be granular or coarse, and you'll see irregularity of nuclear membrane. So those are features that you will not see in HSV. So that is how you differentiate it. All of these you've already answered all these questions, so I'm not going to go into this again. This is CMV. So CMV can be seen. CMV shows this lilac colored intranuclear inclusion. So CMV, we need to remember, is not seen in squamous cells. It can be seen in endocervical cells. It can be seen in mesenchymal cells and in lymphoid cells in a cervical smear, but will not be seen in squamous cells. So that is also something to remember. It will be seen in endocervical cells only. 8th case was L-cell, again discussed by Dr. Hemant in detail. 9th case, this is actually lower uterine segment sampling. So I had shown you a picture of a lower uterine segment sampling. This is a textbook picture. So the importance here is that the differential is hyperchromatic crowded groups. Sometimes these get mistaken for head cell lesions or even for glandular abnormality. So this kind of architecture with stromal cells and epithelial cells at the periphery, you need to think of lower uterine segment sampling. They usually present as long strips. So that is how you'll be able to identify. Sometimes you can make out chromatin patterns, sometimes you really can't because they're really, really hyperchromatic. So it is a very close differential for neoplastic lesions also. But this is something that you need to be aware of in a cervical smear. That is lower uterine segment sampling. So this happens when there is direct brushing of endometrial tissue or when there is a lower uterine segment that has been reached during the sampling for pap smear. The last one was metaplastic squamous cells. Again, Dr. Hemant had discussed it in detail. So not going into that. So that brings us to the end of the session. Thank you very much.
Thank you, ma'am.
Thank you, ma'am. I think Dr. Hemant and you held a humongous task of taking us through the entire spectrum of the pap smear and its lesions. And I hand it over to Charanjeet ma'am for her comments.
Both of you have done a very good job because this is such a big topic, and covering this topic in just 2 hours and covering almost everything. I think you've covered the whole, almost the entire textbook of Bethesda. Such a fat textbook. So this is really commendable, and it was a very well presented. I mean, the slides were very well presented, and I have learned so much today. So thank you very much. Not only me, I'm sure the students have also gained a lot. Thank you.
Thank you very much, ma'am. Thanks to all the students for actively interacting with us and taking part in this. And I think it was very interesting for us to be able to interact with you, and hope you all learned something, and hope you went through the Bethesda textbook, because definitely that is what finally will carry you through. And thank you once again for this opportunity, sir.
Thank you very much. I think excellent. As both my friends have said, Charanjeet and Ram, that you guys have excelled, and students also actively participated. So I congratulate students, for being so active in all this last almost 2.5 hours. It's 9:30 now. There are still 100 students here. They don't want to leave you, Jennifer. So you have something to tell them more. They want to learn more. So thank you very much once again, Hemant and Jennifer, for your efforts, for all the time you've given. And I promise you, I'm not going to leave you. I'll come back to you after a year.
Sure.
Please don't say. And thank you very much, Charanjeet. You've been so kind, and your inputs so invaluable, and it brings a different fresh air, because even the teachers sometimes they need a break for 2 minutes, and then when you give your invaluable inputs, these are like icing on the cake. Thank you very much. And I just want to thank students for having the courage to come online and face Bethesda classes, which many teachers will not know. So as I mentioned, hopefully you will be the very learned today. At least you will pick up so well the liquid-based cytology and Bethesda, that you can boast that if you get a question in the exam, or even if you get slide anytime in your lifetime, you should be able to handle it well. So that's the beauty of these online classes, that the students get exposed to one system. At least that system, when you come and learn from the best teachers, you learn. So you want to say anything, Ram or Mohini?
Actually, thank you, Dr. Jennifer and Dr. Charanjeet and Dr. So you have actually cast up the finer aspects of many things, many finer aspects, which is actually doubtful in pap smear. That was the beauty of today's teaching, actually, because that is the difficult part. Students will always ask that what is this, what is that finer aspects, because everybody can identify squamous cell and cervical cells, but identifying a histiocytes, identifying feather cells, those things are very important. Thank you.
Thank you, Dr. Mohini. Thank you.
That was rightly put, and I think our 150 strong audience at 9 o'clock said a lot about how interested the audience were related to the session, and kudos to all the students for actively participating and raising queries alongside the cases. So I thank each one of you for your participation, and we look forward for a similar participation, because we are going to have a very interesting talk coming up. After cytology, we are going to have a great session on hematology coming up. Again, in the postgraduates, you will be looking at leukemias from multiple facets, starting from your basic slides to your molecular to your cytogenetics, and it will be led by none other than Dr. P.G. Subramanian from ACTREC Navi Mumbai. So we hope to have you all back, and another good learning exercise for all of us. And we'll see you soon. And those of you who would like to catch up on today's presentation, you will again have the replay going on. And please do catch up on what you have missed or you want to listen again. Thank you all for joining, and have a great night.